So these are our disclosures. So TAF has been approved and recommended for first and subsequent line use in children and adolescents living with HIV since 2016. In adults compared to TDF, generally studies have shown no evidence of a difference in effectiveness. And then in terms of safety, TAF has been shown to have a better bone and renal profile safety profile than TDF. And there is some evidence of a greater increase in lipids on TAF, possibly due to a lipid lowering effect of TDF. In children, data are limited to 4 single-arm trials with a combined sample size of only 341 patients, in which viral suppression at 48 weeks ranged between 89% and 100%, and 1 randomized trial, Chappell, which compared TAF versus either Abacavir or zidovudine for second-line use, in which viral suppression on TAF at 48 and 96 weeks was around 80%, and TAF was shown to be virologically superior than the comparator. So in this study, our aim was to describe uptake of TAF and to compare effectiveness and safety of TAF with TDF and also Abacavir, another widely used NRTI, among children and adolescents living with HIV in Europe. So EPPICC, this study used data from EPPICC. EPPICC pulls routine care data from cohorts across Europe, and cohorts were included in this analysis if they were based in a country with access to TAF. So that meant the inclusion of 12 cohorts from 12 countries, as shown on the map. Individuals were then included if they were diagnosed with HIV before 18 years of age. Patients on TAF were eligible if they started TAF before 25 years of age. And to note that anyone who started TAF before 6 years of age, which was off-label at the time of our data collection, was included in the uptake analysis, but not in the subsequent comparative safety and effectiveness analysis. And patients on TDF and Abacavir were included if they started the drug between 6 and 25 years of age since 2013, and that was just to give us a comparator group similar to the TAF group. Anyone who met the inclusion criteria for more than one of the drugs was included in each group. And patients were then followed until drug discontinuation for over 30 days, their 25th birthday, death or last visit, and the date of last follow-up varied by cohort from December 2020 to May 2023. So these were the outcomes we looked at. We started with a description of uptake of TAF. In terms of effectiveness, we looked at cross-sectional viral suppression under 50 copies among those who are experienced at drug start. We couldn't do this among the naive group because of the small numbers starting TAF naive. We looked at time to viral suppression under 50 copies among those who are unsuppressed at start, time to confirmed viral failure over 400 copies, and also change in CD4 count over time. And in terms of safety, we described clinical adverse events among those on TAF, and then compared the rate of treatment-emergent laboratory events and time to discontinuation. So the TAF, TDF, and Abacavir groups were compared, adjusting for key characteristics, including age, anchor drug, and ART history. And to note, we also did a sensitivity analysis where we compared the groups using propensity score weighted samples, and the results from that were similar to the results I'm about to present now, but this wasn't used as our primary analysis because of the reduction in power. So in total, we had 577 patients in the TAF group, among whom 54% had prior TDF use, and the median follow-up time on TAF was just over 1.5 years. So among all children and adolescents in follow-up in our participating cohort since 2016, this corresponds to an uptake of TAF of 19%. There were 428 patients with eligible time on TDF, with a median duration of follow-up on TDF of 2.3 years, and 426 in the Abacavir group with a median time on TAF on Abacavir of 3 years. So this table shows demographic and clinical characteristics at the time of drug start by group. So those on TAF were younger, both at HIV diagnosis and ART initiation, than those in the TDF and Abacavir groups, which likely reflects the later calendar year of use. As I mentioned, we only had 24 or 4% of patients in the TAF group starting TAF naive, and that compares to nearly half of those in the Abacavir group. And in terms of anchor drugs, the most common anchor drug class among those in the TAF group was an INSTI. In the TDF group was either a PI or an NNRTI. And among the Abacavir group, there was a roughly equal distribution across the three main anchor drug classes. So starting with viral outcomes and cross-sectional viral suppression under 50 copies among those are experienced. At 48 weeks, viral suppression ranged between 84% and 89% by group. And in adjusted analysis, there was no significant difference. Then looking at time to viral suppression among those unsuppressed at start, by 48 weeks, between 79 and 86% of patients in the groups had suppressed. And again, there was no difference in adjusted analysis. And that's true both overall, as with the numbers presented on the slide, and also when looking separately among those naive versus are experienced and viremic at start. And then finally, time to viral failure. The rate of viral failure was low, with less than 10% of participants experiencing viral failure by 96 weeks. And again, there was no significant difference between the groups in adjusted analysis. So then immunological outcomes, we looked at change in CD4 count over time, which you can see was roughly steady, again with no significant difference between the groups. So moving on to the description of clinical adverse events among those on TAF. So 16 patients experienced 59 adverse events, which were reported as causally related to TAF. And of these, the vast majority were either grade 1 or grade 2. There were 3 patients who experienced 4 serious adverse events while on TAF. One of these, which was renal colic, was reported as causally related and led to TAF discontinuation. Causality wasn't known for the other 3, but TAF was not discontinued. And then treatment emergent laboratory events. So this table shows the number of patients with any laboratory event of grade 1 or higher, and then unadjusted and adjusted comparisons between the groups, and then the same again for any event of grade 3 or higher. So starting with the grade 1 or higher, about 3/4 of participants had an event, and in adjusted analysis, the rate of events was significantly higher on TAF compared to both TDF and Abacavir. And then looking at grade 3, so overall the number of grade 3 or higher events was low. In adjusted analysis, the point estimates comparing the groups were very similar to the analysis for grade 1 or higher events, but because of the small numbers of events, likely the confidence intervals were wide and the p-values non-significant. This graph then shows or compares the rate of grade 1 or higher events between the 3 groups by laboratory marker. So dots above the purple dashed line represent a lower rate for that marker on TAF, and dots below the line represent a lower rate on TDF or Abacavir. So we see here that for several of the lipid markers, the rate of events was lower on TDF compared to TAF, but there was no difference with Abacavir. And then there was no difference in any of the bone or renal markers between any of the drugs. And then finally, looking at discontinuation. So among those who discontinued, the reasons for discontinuation are shown on the slide. Across all groups, the most common reason for discontinuation was simplification or optimization, with very few participants discontinuing for either treatment failure or safety. And then accounting for competing risks of discontinuation for simplification or optimization or for unknown reason, by 192 weeks, the proportion of patients discontinuing TAF was lower than in the TDF and Abacavir groups, and this difference remained after adjusting for key characteristics. So in conclusion, this represents the largest study of children and adolescents on TAF to date. We have demonstrated that TAF has similar effectiveness to TDF and Abacavir, with estimates in line with those from clinical trials. We saw that few patients had severe or life-threatening clinical or laboratory events, although there were increased rates of lipids events on TAF compared to TDF, but not Abacavir, and there was no difference in bone or renal events. I'd also like to highlight that we've compared growth and weight gain between these 3 groups, and the results from that are on poster 87 outside. So to conclude, as TAF becomes increasingly available in low middle income countries and in younger children, there is need to confirm these findings and assess longer term outcomes. I'd like to acknowledge all our patients, clinic staff and cohorts who contribute to EPPICC, as well as the wider EPPICC team. Thank you.